Hi, everyone. So I do work for Viela Bio, but I need to disclose that the work that I'm going to present was from my time at Johns Hopkins and doesn't necessarily represent the opinion of Viela Bio. So new trends in pain management, and Dr. Nicholas really segued me well in terms of her talk to mine, and there'll be some crossover, and so first I'll just start with persistent pain. So it affects approximately 100 million people in the US and costs upwards over $500 billion annually. And we've discussed a little bit about the differences between types of pain, so I can go through this fairly quickly. In terms of, there can be primary pain, such as directly from the injury, as we've talked about, and then there's also other types, including secondary pain, which is the wear and tear. Your body's meant to move in a very specific way, and so when you alter that because of weakness, it can cause a lot of stress on the joints and on the tendons and cause secondary pain that's not directly related to the spinal cord or brain injury. And then tertiary is really just how you cope with the pain, how that affects you and the pain that can cause you emotionally. So we've talked again about neuropathic and spastic pain, so we can try and do some catch up now, including what causes pain. What we've learned from MS and NMO is that in MS, the prevalence of pain is between 29 and 86%, and those MS patients who have lesions in their spinal cord have more pain than those who only have disease in the brain. In NMO, the prevalence of pain is between 62 and 91%, and it tends to be more severe and debilitating and persistent, impacts quality of life more than other symptoms, and is refractory to most available treatments that are used. The burden on patients is such that it really impacts quality of life. In some small studies, specifically in NMO, which, as you've learned, is a recurrent form of transverse myelitis, it's associated with increased depression, increased difficulty with ambulation, decreased enjoyment of life, and pain is the best independent predictor of poor quality of life in NMO, more so than immobility and bowel and bladder problems and all the other symptoms that we've been discussing. Importantly, though, research in cancer has suggested that if you look at a symptom in a silo without considering the whole individual and only target one specific symptom, that doesn't necessarily have impact on quality of life. You really need to look at the whole person, and luckily, pain is one of those symptoms that really affects other symptoms. So if you were to target pain, it may have benefit to your sleep. If you're not sleeping because of pain, it may have impact on your mobility and on your mood, your sexual dysfunction, and even your bowel and bladder dysfunction. And it goes both ways. Each of these things are also causing more pain potentially. So really looking at things in a holistic manner when your practitioner is addressing treatment is an important thing to remind them of. So currently available treatments are off-label use of anti-epileptics, antidepressants, and some NSAIDs like ibuprofen. And so you'll see a bunch of these named here. And I'm sure some of them will be familiar to you. Some of you have been on many of these. And the problem is that there's frequent use of multiple medications and frequent breakthrough need for opioids. And the side effects of particularly combining medications is associated with slower reaction times and fatigue. And so it's already been discussed about optimizing the dosing of some of these medications. It's an infinitely frustrating process, and it takes weeks to months, more often months. And of course, that's time that you're in pain. But I would really encourage you to try to, as Dr. Nicholas said, be very patient as much as you can be, and make sure you keep a very good record of what you've been on, because, you know, doctors and nurse practitioners are seeing so many patients, and you're really your one best advocate and really know what you've been on, and so keeping track of your history is always a good idea. Combining medications from different classes can be more beneficial than trying the same medications from the different medications from the same class. And then also, as was also alluded to, combining with non-pharmacologic interventions can really enhance the performance of the pharmacologic intervention. So it's more of a synergistic benefit when you combine non-pharmacologic with pharmacologic medications. Now, more recently, there's been a lot of excitement about cannabis use for pain in these neuroimmunologic disorders. It's been shown to be beneficial in autoimmune diseases of the nervous system. And endocannabinoid system plays an important role in the neuronal circuitry. Preclinical studies support analgesic effect, and there is the additional antidepressant-like effect. There's been a lot of debate about the use of these medications, the CBD versus the THC. The CBD is the part that really impacts your pain. The THC is the part that makes you high. And so there is a lot of attention to research in terms of trying to have medications that really can concentrate on those CBD beneficial effects without exposing you to the THC. This is a map that I showed 2 years ago at this conference, and luckily I was able to fill in some more states, so that's good news. There's only 3 states where there's absolutely no cannabis available at all, and then in the orange you'll see limited use of medical use, and then in the blue is medical use, and then in green is where it's openly accessible. So there are certainly, you can infer from all of this, a lot of gaps in the research, in the current treatment. And because of pain being intractable to what's currently available, and there is a lack of research. So if you were to do a search on clinicaltrials.gov, you would find 2 studies come up specifically in rare autoimmune diseases of the central nervous system and pain. The first trial I'll talk a little bit about, but I can't get into much detail. So this trial was done at Oxford and Liverpool, were the 2 sites for this trial. And I've talked to both of the doctors who were the primary investigators, and neither of them have heard any of the data. So I don't have any data to present on that one. I'm very sorry to say. But basically, it's a medication, daily medication that modulates activity of the endocannabinoid neurotransmitter system. So it enhances your internal cannabis, basically, and how that's produced and how it's used in your body. This trial included patients with TM, NMO, and MS. So the one that I'll spend more time talking about is Scrambler trial for pain in NMOSD. Dr. Nicholas did refer to Scrambler therapy. That was not a setup. This just happened to segue, as I said, well into my talk, because I'll be spending quite a bit of time on this. So again, this comes out of research that Dr. Levy and I did at Johns Hopkins. And so Scrambler therapy is similar to TENS. Some of you may have experienced TENS, where you get the vibratory sensation, transcutaneous electrical nerve stimulation. But Scrambler more specifically targets nerve fibers that are responsible for chronic pain in a scrambled waveform. And so you surround the pain area and you send variable waveforms to the brain, and it is thought to replace pain with no pain information. So this is what the Scrambler machine looks like. And this is one of the oncologists hooked up to the machine. And there has been 26 peer-reviewed reports, mostly observational, open label, in peripheral neuropathic syndromes. And there have been 2 reported case studies, both out of Hopkins, in central neuropathic pain, and one of which was in TM. And overall, it reduced pain and seemed to be safe. So taking that, we decided to do a randomized controlled trial in NMO. We included 22 patients, and 11 received treatment, and 11 received what's called sham, which is essentially placebo, but in devices we call it sham. And it is meant to mimic the treatment. And so patients with persistent pain rated at 4 or above received treatment or sham if they had the diagnosis of NMO. We used the established protocol for delivery of Scrambler therapy over 10 consecutive weekdays, and then sham emitted a vibratory sensation that mimicked that feeling. So this is essentially what the visit schedule looked like. The important part is patients received 10 treatments, and they were followed for 60 days. Our participants, by randomization, were such that it was very equally distributed. In general, they were women of any ethnicity with a mean age of about 56, 57, and their baseline pain was similar across groups as well as their treatment prior to being enrolled in the study. So here's what we found. The way this is divided, oh, I do have that same mouse. You'll see this, where is it? You'll see this pie here. It keeps disappearing on me. Anyway, the very dark, the darker of the teals there are people who were complete responders. So after 10 days of treatment, those patients, 36% of them, went from a pain level of 4 to 10, whatever their pain was rated at on the numeric rating scale, to 0. Those were what we defined as complete responders, those who ended up with no pain at the end of the 10 days. Those with partial response are ones that had essentially 2 or more point drop in their pain, which has been shown in spinal cord injury to be a clinically meaningful reduction in pain. So another 4 people, another 36%, were in that partial response group. And then only 3 patients, about a quarter of patients, had no response or had suboptimal response. Whereas in the sham group, nobody was a complete responder to this treatment. Nobody's pain went down to 0, which isn't too surprising, but we do expect to see some placebo effect, and about 45% of patients had a partial response, whereas 55% had no response at all, or a suboptimal one. And so not only did people seem to have decreased pain, but the amount of pain the amount of impact that they had on their pain was significant, such that if you look at these bar graphs, and if you look at the pain scores there on that axis there to the left, you'll see the pain ratings. And that box there shows you, I'm getting nervous because I can tell my slide's on auto right now and it's about to go ahead of me. But so that box shows the higher the box, the more pain, essentially. Yep. And so, sorry about that. And so you can see that at pre-treatment, you had your highest level of pain, whereas at the end of 10 days, it was reduced significantly from about a 5 to about a less than 2. And then it did go up at 30 and 60 days, but it was still significantly reduced at 30 days, suggesting that patients might need more frequent dosing of this. Darn you. But I'll just let you know that that wasn't the case in the sham group. It's not letting me back up. Well, you know what, that's probably letting me know that I don't have a lot of time. So I'm going to just let you know that there was also an effect. We also looked at symptoms. Again, I discussed with you how if you just look at one symptom in a silo, then it might not impact quality of life. So we wanted to look at sleep and anxiety and depression as well. And what we found is that we were able to change pain scores. Oh, darn it. Okay. We were able to change pain scores in the depression scores in those who received treatment, and it was a significant drop all the way to 60 days, whereas that wasn't the case in the sham group. I'm going to back up here and also let you know that patients didn't know if they were on sham or on treatment, which is important in a study like this to maintain the integrity of blindedness, because that really adds to the ability to interpret correctly your results, that they really are meaningful. And patients, the same number of patients finished the trial no matter which group they were in and wanted to continue. And we didn't see any safety signal. We had one patient who had a port infection during the follow-up period who was on the sham retreatment anyway. So again, we saw some meaningful improvement in depression. We did not see that in anxiety or sleep, but if we did look at those 75% of patients who were responders, they did in fact have an impact on their anxiety scores as well. Unfortunately, that wasn't the case with sleep, although that's not necessarily surprising since oftentimes that's a measure that can be delayed in terms of response. So pulling it all together, we have now a better recognition of the impact of pain, and the use of Scrambler therapy in NMO supports use in TM and other rare neuroimmunologic disorders, and effectively treating pain may improve other symptoms, including depression and anxiety. But on the horizon, so that's only 2 studies, unfortunately, but I did do a search again of clinicaltrials.gov and saw that in spinal cord injury at least, there are a lot of trials going on. And so that may not be something that you'd be eligible for at this moment, but it is something that potentially could work out for you all sitting here in the audience in the future. Some of those things are listed here. I won't go through them in any detail because I know we don't have time, but from this work that was done at Hopkins, I really want to thank the people that were involved in this study, most especially Michael Levy, but above everybody is my patients, because it was really coming to clinic every day for 10 days straight, oftentimes from far away. And we don't have time for questions, but it's still, you deserve to see that picture. Although you've seen the live version over these last few days, and that's it. So thank you so much.